Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for June 9th, 2022. Today's CME activity code is 485758. This conference is being recorded. As usual, we have nothing to disclose, and the patient confidentiality has been very well preserved, with identifying information including age, gender, ethnicity, dates, exact laboratory values, and other details have been changed to disguise the identity of the patient. Today we've got a great case. Dr. Gashti has put this together. I'm told it's very, very unique. And so this will be a lot of fun. Casey, I think you have the protocol. You wanna read for us?
Yes. So our patient is a 22-year-old female from Central America who presents with fatigue, photosensitive malar rash, arthralgias, oral ulcers, hair loss, myalgias, dry mouth, leg swelling, and pressure over her chest. So a whole slew of complaints. She's not feeling so well. Upon further evaluation, she was noted to be very hypertensive. Blood pressure was 160/90. Preliminary labs showed a serum creatinine of 1.6, and her urinalysis had 2+ blood and 3+ protein, with a quantification of protein to creatinine ratio of 5.8 grams per gram. At that time, she was referred to rheumatology, and they did further serologic workup, which was significant for a mildly positive ANA with a 1:80 nuclear homogeneous pattern, but otherwise negative for anti-double-stranded DNA with normal complements, negative ANCA and GBM. So she was then sent to nephrology and underwent a kidney biopsy to further evaluate the cause of her creatinine elevation and proteinuria hematuria. Of note, this patient has actually had intermittent gross hematuria since she was 2 years old. Her father also has a history of intermittent gross hematuria, as well as an ectopic kidney and hypertension. He has never been biopsied. He still lives in Central America. He's not here. And his GFR is unknown. She has 2 siblings. She has a younger sister who has a history of intermittent gross hematuria and unable to hear from one ear, although she actually has an external auditory deformity. She has a brother who doesn't have a history of any hematuria or hearing problems. Her past medical and surgical history are only significant for gross hematuria. She is a non-smoker. She drinks socially, and her family history is significant as above. No allergies, doesn't take any medications. Her review of systems have already been mentioned. She still has fatigue. Her rash is really it's a sun-sensitive facial rash, and it's also present on the upper part of her chest. The other review of system items are as per above. She did complain of intermittent leg swelling as well. Physical exam, she was hypertensive, 164/90, a febrile, 130 pounds, 5'1", with a BMI of 25. She appears pale and relatively anxious. Her cardiovascular as well as pulmonary exam were normal. Abdomen was soft. She has sort of a rosacea pattern of rash over her face, and she has trace bilateral lower extremity edema. She did not have any oral ulcers at the time of my visit. She had thinning of her hair with no patchy alopecia and no nail or skin abnormalities and no synovitis. Her chemistries show a sodium of 136, potassium of 4.2, chloride of 106, bicarb of 22, BUN and creatinine of 31 and 2.0, glucose of 88, normal calcium, total protein 6.5, albumin of 3.4, LFTs and other liver function tests were normal. Her white blood cell count was 12.5, hemoglobin of 12, and platelet count of 300. Her autoimmune serologies have all been listed here, and they were all negative. The repeat ANA that I did was negative. So were her ANCA, DNS, Dosin, DNA, SSA, SSB, anti-Smith, PLA2R were all negative. Complements were normal. SPEP had no monoclonal spike. Viral serologies, including COVID, were negative. Her coags were normal. Her UA, she had a specific gravity of 1014, pH of 5, 3+ protein, 3+ blood, 3 WBCs, 17 RPCs, and negative for ketones, bilirubin, leukoesterase, nitrite, and so on. Her urine protein to creatinine ratio, when I repeated it, was 3.7 grams per gram. Her renal ultrasound showed bilateral echogenicity left at 10.1, right at 9.8. There were no cysts, hydro, or stones. After initiation of antihypertensive therapy and some improvement in her blood pressure, a percutaneous renal biopsy was performed.
Great. Do we have any questions for Dr. Gashty?
Casey, the rash was only on her face. She didn't have it in the abdomen or anywhere else.
No, it was actually upper chest as well. It's essentially like a sun rash, as opposed to no, she didn't have anything in her extremities, in her thorax, abdomen.
Good. Well, I think I'm going to tackle this one this week. I always say if you can tell a CPC in the New England Journal of Medicine from the first sentence, and if you can't, you're not going to get the case. But this has two parts to this first sentence. So 22-year-old female from Central America, and then immediately start worrying about IgA nephropathy because of the strong association with that. But when you actually finish the sentence, it takes you in a whole different direction. I might add that I'm going to discuss this in the context of someone who has renal insufficiency. Creatinine seems to be climbing, has nephrotic range proteinuria, but a fairly active urine sediment. She does have some renal echogenicity, so this appears to be chronic. So maybe an acute on chronic GN, but there's a lot of things that point to this, to me, more of a nephritic type of differential diagnosis than a nephrotic diagnosis. I love these terms. I still think they're relevant and very useful when we approach things clinically. So I mentioned at first, she's 22, she's from Central America, and I start IgA nephropathy, but that quickly falls apart because she has fatigue, photosensitive rash, not just, a malar rash, photosensitivity, arthralgias, oral ulcers, hair loss, myalgias, dry mouth, leg swelling, and pressure over chest. I mean, if this doesn't say lupus, I don't know what says lupus. And she's also, Hispanic, which is more common to have lupus, and a young woman, more common to have lupus. And so I would stop there, except it gets a little more complicated when we get to her serology. But, if from the first sentence in my, point that you can tell what it is immediately, I would have to pull a Bill Whittier and say my top 10 diagnoses are lupus nephritis. So as Bill will be the first to admit, that's always the kiss of death in the diagnosis if you make something the first 5 or the first 10. She's hypertensive, she's got some renal insufficiency, and she's got a very active urine with nephrotic range proteinuria. And so, of course, she gets sent to RUM looking for lupus, and all they can find is a mildly positive ANA at 1 to 80, nuclear homogeneous pattern, but double-stranded DNA, complements are normal, negative ANCA, negative GBM. Now, serology isn't everything. We certainly have something called ANCA negative vasculitis, and I think there's probably ANA mild lupus, but I can't say I've ever seen anybody with really significant clinical lupus to this degree with this many symptoms and nephritis that's fairly impressive, that only has a positive ANA 1 to 80, and then when Dr. Gashty checks it later, it's now negative. And I'm not saying it doesn't occur. There are certainly, lupus-like lesions. It looks like lupus, it's seronegative, but they don't usually have all these symptoms. They just present with GN. So, I think that's still very high on the list, but it's not as high as it was initially on my list. So what's after that? Well, she is Central American, and that gets me back to my IgA nephropathy. She has this history in her family she's had a history of gross hematuria. Gross hematuria can happen in just about any GN or so, I'm told, but typically, in my experience, it's post-infectious GN, IgA and IgA nephropathy are by far the most common causes of gross hematuria. She's had recurrent gross hematuria, which now, IgA nephropathy gets moved way up, and then you start seeing that she has this family history with some gross hematuria. Well, now it's not a monogenic disease, but the fact that there's more family members that might have it makes me, even more concerned about it being IgA nephropathy. Her dad has a history of intermittent gross hematuria. Interesting. He has one small kidney. I think that's probably a red herring. She has 2 siblings. We don't know about her mom, but she has 2 siblings, a younger sister who has a history of gross hematuria, but unable to hear from one ear. I'll get back to that. That's kind of crazy. And a brother who does not have a history of hematuria or hearing problems. So, I'm kind of left here with, the possibility of this being strong possibility of this being IgA nephropathy, but let's look at it a little more now. What about some hereditary nephritis? Because there's a lot going on in this family, more like a monogenic disease or X-linked disease. She's got a sister who can't hear out of one ear. I don't know about, first of all, hereditary nephritis in women has a quite variable presentation depending on how much, how much of the 50% of their chromosomes, half of their X's will have the abnormal gene. But how it affects them phenotypically depends on how much is in each organ. So, most women, it's pretty asymptomatic, or they'll have some hematuria, but occasionally patients can have end-stage renal disease if they have a very large dose of the abnormal gene in their kidneys. I'd never heard about it only affecting one ear, though. And when that one ear has a lot of the abnormal collagen gene and the other one doesn't. So I think that's a red herring. And also, Dr. Gashi said there was a structural abnormality. And I know there are a lot of otorenal syndromes, like a whole lot of them, that come out in the pediatric literature. I'm not going to even try to get into that, but it is an interesting thought here that, that she might have one of these strange otorenal syndromes that go way beyond, typical Alport. So I think I'm not excited about that. She's a brother who's normal, but that would be a 50% chance anyway, So I'm not going to go there anymore. It's just kind of interesting. I have read that people with Alports can have gross hematuria, but I've never seen it. Then again, I've not seen a lot of the disease. What about, just other nephritic syndromes like a vasculitis, ANCA negative? Now we've got to have an ANCA negative vasculitis. Yeah, I suppose it's always possible, but, with the being Hispanic in the family history, I'm thinking IgA nephropathy, that she's had it a while. She's had it a long time. And what we're going to find is some degree of IgA nephropathy now. It could be crescentic, but not necessarily, because, she's had it, by history of her gross hematuria, she's had it most of her life. So I don't even think we need to invoke that crescentic GN, although her creatinine is going up a little bit now. But, that could be fluctuation of blood pressure and everything else. They treat her blood pressure, her creatinine is going to go up. No surprise whatsoever. What am I missing? Other nephritic syndromes, I suppose, some MPGN or something else. I don't know. There's probably a long list, but I think that covers it from what I can think of pretty well. Bill or Steve, you have anything to add? What'd I miss?
Steve, you want to go, or you want me to start?
No, you go, and it'll give me more to talk about.
Yeah, I'm glad I don't have to follow Dr. Corbett, but it was hard to follow Dr. Robbie there because it was
Exactly.
a great differential. I would have approached it the same way. It's got to be lupus. Oh, nope. Now it's got to be IgA. Oh, maybe it's something familial. And that's kind of what I was thinking as I was reading through it as well. To the familial ones, I would add, could it be something like a strange Fabry's? That's very unlikely. I don't think gross hematuria is a huge part of it, but it could be. We think about skin rash, but it's usually not the photosensitive one on the malar area. Usually it's either in the areas of pressure distribution, like where a belt line would be or something, and she doesn't really seem to have that, but I would think about that. And then there's also, when they're nephritic and nephrotic, I think about MPGN quite a bit, and abnormalities in the alternative complement pathway could lead to a overactive complement system over time without having hypocomplementemia, and that can lead to an MPGN pattern. And those could be familial too, because you could have a factor H hereditary deficiency or something like that too. So those would be the only other things that I would add. But again, those are really pretty big stretches and pretty rare, considering I can think of maybe 2 or 3 cases that I've seen of those in my life.
Steve?
I mean, I agree. The differential was excellent. I mean, the more I thought about this, I agree. I was thinking some, familial form of IgA nephropathy. I think there was a pediatric nephrologist, I think by the name of Wyatt, years ago, who would, before people thought IgA could be familial, reported families that had this. Some kind of strange Alports, instead of alpha 5, an autosomal dominant with alpha 3, alpha 4 chain abnormality. And I was also thinking, as has been mentioned here, some form of familial FSGS, but they usually don't have gross hematuria. I guess they could, but in this case, we'd be talking about alpha, an autosomal dominant, which would basically be, an abnormality in either TRPC6 or alpha actinin 4. The only other thing I was trying to think about, as far as you said, this was something weird. And I remember way back before APOL1, there was this whole issue of whether myosin heavy chain 9 was associated with renal disease as far as familial forms of FSGS. And, they had odd situation. There's where you got the Howell-Jolly bodies, which was the clumps of myosin heavy chain 9 and white cells, which you don't describe here. And they would have clumps or large platelets, which you don't describe, but there was a syndrome I think called Sebastian syndrome, and I kept thinking, as you were talking, that maybe that was associated. I know it was associated with something other than renal disease and the hematologic manifestations, and I can't remember if it was hearing or not. But those weird things were the only ones that were coming up that you've covered most all of it, and I think the fact that you led this off by saying it's something weird. I have a feeling he sent something off that after we get the biopsy, we'll get a result back from Natera, and then we'll really be stuck with trying to figure out what's going on. But I think you've covered it beautifully, and I don't know that I really added that much more.
Well, I've been told it's something weird, but I think it still has to be discussed in what the data would suggest. And I'm glad Bill brought up Fabry's. I never think of that. And
no, I'm not disagreeing with discussing all the possibilities. I'm just saying that as you do that, you start second guessing what's really the right answer.
Yeah, exactly. And also they brought up the the MPGN and maybe because there are hereditary complement deficiencies. Dr. Glassick, Dr. Rubin, anything you want to add?
Roger, can you hear me?
I sure can.
I think the notion of Fabry's disease is very attractive in this case. A history of hematuria in a woman beginning at age 2 with this family history that suggests an X-linked disorder. The fact that she has nephrotic range proteinuria, but no nephrotic syndrome and is not hypocomplementemic. I think she has lupus. I don't think there's much doubt about that. And it's probably seronegative lupus. But I would rather think that this may be a case of Hickham's dictum. Patient's got 2 different diseases, Fabry's. Alport's, I don't know, that would be a little less attractive because of the very early onset of the disease in a heterozygous female. But I would be attracted to Fabry's actually, and not IgA nephropathy.
Fantastic. I know I'm colorblind, but I think Dr. Whittier might be blushing. That's his choice. Dr. Rubin, you have anything to add?
No, I think she has some sort of hereditary kidney disease.
There you go.
Whatever that is.
So we have a poll we're going to put out before we show the pathology. So what is your clinical diagnosis? Please vote, everyone. We have no way of telling. Do we think it's lupus nephritis? Do you think it's ANCA-negative vasculitis? Do you think it's IgA nephropathy or a hereditary nephritis? We put a hereditary because it encompasses a lot of things. This is really interesting.
Right. So let's see, give it a few more seconds here.
This is really interesting.
Yeah, this is going to be good.
I get to see the votes as they come across, and I'm shocked.
All right, 80% in. All right, and poll, we'll be able to, everyone should be able to see the results.
So we have about 38% say lupus nephritis. Nobody bought ANCA-negative vasculitis. Only 2 people picked my top choice, IgA nephropathy. And I guess when Dr. Glassick speaks, people listen. So we have the highest vote is a hereditary nephritis with, and the same thing with Dr. Rubin. So I would love to have seen the vote before they spoke, but I can't blame people for voting, because these are some very brilliant people and very smart. So our biggest vote is for hereditary nephritis. So let's see what it is. Let's spin the wheel and we'll see about the pathology.
Hey, Roger, unmute yourself. Sorry. You're muted.
Okay, Dr. Corbett.
That would be me.
All right, give me a second here. All right, and I'm going to give you a remote control here. Give me a second. Go ahead and click on the screen.
Okay.
Yep. And then you can see the arrows at the bottom to advance the slides.
So we have a trichome right here, which shows a fair amount of tubular atrophy and interstitial fibrosis, probably 50%. At this power even, I think there's some glomerular sclerosis as well. You see other glomeruli that don't look so bad. I think here's a sclerotic one, here's one, I think here's one. Again, we'll get a higher power, but so far, I think the main thing here is the interstitial fibrosis and tubular atrophy in about half the sample.
Yeah, I agree with everything you said.
Next. PAS, vascular pole here. You can see the take off the proximal tubule here. Boy, the mesangium looks pristine. There's no increase in matrix or hypercellularity. I mean, this glom looks completely normal. Can you see my arrow or no now?
Just click on the screen again. There you go.
Okay. Can I? Well, so anyway, this looks pretty good. Pristine, exactly, Roger. That's my term. Oh my God. Well, here we go. So here we have this huge cellular crescent with a little tuft of what's left of the glomerulus here, and you see this inflammation on the outside. It's probably monocytes and lymphocytes, a reaction to this crescent, I'm sure. So now we have whatever else is going on. We have a crescentic lesion, which I don't think many people voted for a vasculitis from my recollection, but this could be an IgA vasculitis. Next.
Yeah. And then I just point out there's some ATN in the tubules to the right. Loss of brush border.
Yeah, I was so fixed on the damn glomerulus, on the darn glomerulus, yes, you're right. There's evidence of ATN as well. And here we have another PAS. We have a nice segmental scar, perihilar in nature. Now this one shows a little more, I think, in the way of matrix expansion. These basement the brush borders looked pretty good, actually.
Yep.
Here we have some of the tubular atrophy that we saw on the trichrome stain. On the Jones stain, boy, this is beautiful. I mean, I don't see anything. There are no holes in the en face view of the basement membranes. There's no double contours out here, no spikes. I mean, this looks normal to me.
Yeah.
Here we are back to an H&E, and I think here's where we see really significant global glomerular sclerosis. And a lot of tubular interstitial fibrosis and atrophy.
Yeah.
I think this is what I guess if we look at this one, you can see where there's a fibrous crescent, and I don't know if this is what's left of the glomerulus. but this
Yeah.
is probably a remnant of what we saw very actively a few slides before. Another one here, again, this is all sclerotic. In all honesty, and I know I'm probably overreading this, but David, you can comment. And the subtle difference in the pinkness here as well as here makes you wonder whether one of these is on the fluorescence. We'll see fibrin.
Yeah. Yeah, so there were 12 gloms in the core. 8 were globally sclerosed. Couple with segmental scars, as we saw, and then 1 had the cellular crescent.
Wow. And this is somebody who had a serum creatinine of 2.0. Now, I don't recall what her size was, but maybe she was fairly petite. Here we have a PAS again showing more ATN.
Yep. Good.
I'm looking
sloughing
for a
of
mitotic
cells.
figure here, but I don't see it.
Yeah, I don't think there was one present in the biopsy.
Okay. Okay, so here we go. Did you take a picture of an actual glom here, David? Or is this...
Yeah, there's one there hiding, but
yeah, hiding way off over here. It has IgA in it or something. But no, I don't see anything here, not even background. So this was very negative with, I assume, positive controls.
Yeah.
And so then the electron micrograph, the basement membranes, look pretty normal in thickness. No not surprisingly, you don't see any subendothelial deposits. There is fairly good effacement of the podocyte. We don't see any real basket weaving. This isn't thin for sure, which may have come up. There's no basket weaving to think of in Alports. And as was brought up by Dr. Whittier and Dr. Glassick, the issue of Fabry's is kind of, so far, we don't see any of these myelin-like figures. So that's kind of out. I guess maybe we see a mesangial might be better.
But Steve, it's subtle, but up at 12 o'clock, the GBM is a little irregular.
Right here?
Yeah, and there's a little, it's a little thick in there. And if you keep traveling around, there's some areas of like internal lucency that it seems to be, an irregular appearance. We'll see it at higher power. It's kind of subtle.
All right, but are you trying to say this is basket weaving in nature?
Well, go to the next slide.
All right. Well, again, it is irregular. There's some fluff in between. How would you, here the podocytes don't look too bad. How do you describe this, David?
Yeah, it has an irregular appearance. I would say there's an internal lucencies. It's certainly suggestive of a hereditary nephritis.
Fair enough. And I assume at some point here, if we're going to go down this pathway, you're going to show us some alpha 5 staining and alpha 3 and 4.
Yeah. Well, so this was an outside case, and I didn't have tissue to do those stains, but I did suggest the EM findings are suggestive of hereditary nephritis, and genetic testing should be considered.
Well, hereditary nephritis, like Alport's hereditary nephritis, or something else?
Yeah.
Okay, because I think we'd narrow it down a little bit here. So if we're going to say this is more or less basket weaving, the other thing they talk about is kind of thick areas and thinner areas, but I didn't really see anything that looked like, the thinner, like thin basement membrane that you can see kind of coexisting with this. But fair enough. So we've got this irregularity in the basement membrane. So this wasn't a transplant, was it? So we've got this person that has, EM findings consistent with hereditary form of renal disease, i.e. Alport's. And coexisting with this is a crescentic pauciimmune lesion, along with some ATN and a fair amount of scarring, which means one of these two processes, whether it's the hereditary nephritis or more likely than not, whatever's causing the crescentic glomerulonephritis is causing her to have a fairly aggressive course with a lot of glomerular scarring. Whether 8 out of 12 represents what's going on throughout, may or may not, but irrespective of, we've got a pretty significant lesion here with, I guess, an underlying hereditary Alport's, if you will. So I guess that in this case, the ANCA, and I don't remember, and as I didn't write it down, whether we had an ANCA, but the ANCA becomes important, and for sure, the genetic testing becomes critical.
David, how many Glom's head crescents?
1 out of 12.
Okay, I'm sorry, I might have missed that. I'd like to point out we have a celebrity in the audience today. Astrid, I don't know how to pronounce last name, maybe Vines or Vines, but she's a renal pathologist at the Brigham. And with the first EM, she was suggesting that there was abnormalities, and just later went on to say that genetic testing would need to be done to take it any further. So welcome. We're certainly glad to have you. And I want to point out the clever chat of the week is Dr. Rubin, who said zebra bodies are missing, but this is a zebra. And I think that says it all. That's the tagline for this case today. I think we have a poll before we get any more information about follow-up and diagnosis. I know it's a little unfair, but at this point, how would you treat this patient? Because realize there is a crescentic GN, but there's also suggestions of a primary genetic hereditary nephritis. So would you give RAS inhibition with or without SGLT2 inhibition? Steroids with MMF, steroids with rituximab, steroids with cyclophosphamide?
All right, we'll give it a few more seconds here. A few more. There we go. All right.
So we've got 40% treating conservatively. Then we have about a third that's treating with rituximab, and about a fourth that are treating with steroids and cyclophosphamide. In the chat box, Dr. Hussein asked, would one crescent be enough to label a crescentic GN? And I don't want to get into that discussion because I always have had a problem with that. First of all, we have a small sample size. But what we do know is this patient has very active urine sediment, has a crescent, has a lot of glomerular sclerosis from perhaps crescentic disease or perhaps maybe hereditary disease. And that may be the crux of this. But I don't like, defining a crescent by amount of cells and what percent it fills the glomerulus and how many crescents you have. I'm not a big fan of that. I like to think more pathophysiologically, but realizing the importance of nomenclature. But that, we can get into that perhaps. So let me ask Steve, what would you do with the information you have thus far? Dr. Corbett.
I know, I'm thinking. Well, I for sure would give her, RAS inhibition. And then the question, is which of the next three? And I'm between the for sure steroids, and I'm between Rituxan and cyclophosphamide. I mean, there's a part of me that says, this is. I personally think that a lot of that glomerular, the scarring was a result of this crescentic disorder, if you will. Again, I think that we saw some fibrous crescents there, which I think were indicative of what happened prior to the scarring. Anyway, I don't know that we've got a lot of room here to lose any more function. So I personally would be leaning towards cyclophosphamide, but at the same time, in a young woman, rituximab. I'm kind of stuck between the two, and would discuss it with her.
What do you think is going on? Do you think she has a genetic disease and ANCA-negative vasculitis?
I do.
Okay. Anybody else have any thoughts? How they put this together? Dr. Glassick, Dr. Rubin?
I also think that the hint, what's causing the damage, what's causing your creatinine to be high, kind of like Steve said, is it crescentic disease, or is it underlying basement membrane abnormalities, or is it one is a hit and the other one's but the fact that there were some segmental scars to me means that there's probably been previous damage from an inflammatory, like that's not a focal sclerosis, it's a segmental scar from previous vasculitis, and crescents are there too. So it seems to me that she has glomerular dropout due to this inflammatory lesion, and that would make me want to treat with I'm sure there's no studies of any of this, but it would make me want to treat with, steroids and Rituxan or steroids and cytoxin. I mean, in addition to an ACE inhibitor too, but I would probably want to hit her with something, and I would choose, just because of her age and the fact that there's already a lot of glomerular obsolescence anyway, I would probably just use steroids and rituximab and not go to the full cyclophosphamide.
Everybody keeps saying that all this glomerular sclerosis was of the crescent. And, I think when Steve pointed at that one, it kind of had the sense of that. But David, can you really, they just look like dead glomeruli. Did you really think they were old?
My only point to that was that we did see one with a segmental scar. There was one there with a I think it was perihilar, if Steve said that, or maybe it was
Yeah, it was.
That one was telling me more that it's the segmental disease more so than the global sclerosis that we saw.
I mean, the problem there is it could be that segmental sclerosis could be from her hereditary disease too. I mean, it's just
Right.
It's hard to know. But this one there, this one glom, I don't have that up here in this right upper corner. Well, now we're past it. The right upper corner, you can see what's left of the glomerulus, and then around it, you can see this fibrous crescent, and that's kind of what made me wonder that this had previously had an active crescentic lesion. And even the one down below, if you follow down below on the same side, that glom kind of gave me the same impression, but that obviously is very soft.
Yeah, I can see why, but I know a lot of, glomeruli, when they become totally obsolescent, kind of look like that, but I'm not the pathologist here, so I'm going to already cross that line. Casey, Dr. Gashti, teach us something about this case. Instead of confusing us. Anka's been persistently negative.
I'm so glad you guys are as confused as I was when I saw her. So so we have this woman who presents with what looks like lupus, and then has this family history of hematuria, and then the biopsy shows a post-immune crescentic glomerulonephritis. So can I get my slide control? Is that me? Okay. All right. So we did do genetic testing, and she is actually positive heterozygous for alpha-5 chain mutation of type 4 collagen. So this is consistent with X-linked Alports in a female. And I'll go through just briefly like what that means, and then sort of what's interesting about this case is, yes, the Alports part is interesting, but then what about the crescentic GN? And that also there is some cases that have had pre-transplant crescentic Alports. There is definitely reports of post-transplant when they develop anti-GBM disease where they present with crescentic GN, but this is in the native kidney. So that's unusual and rare. So Alports, as we mostly know, it's a progressive hereditary renal disease, which also includes bilateral sensorineural hearing loss and ocular abnormalities. And that's really due to the presence of the same three strains of alpha chains, which are alpha 3, alpha 4, and alpha 5 in all the glomerular basement membrane, the cochlear basement membrane, and the base of the ocular lens. Unlike other types of collagen, I learned that collagen is, there are 6 different alpha chains of collagen, and there's collagen throughout the body, but collagen is organ specific. So for example, skin basement membrane or Bowman's capsule, for example, are alpha 5, 5, and 6. So that's a little bit different, and that has some fluorescent implications when we look at some of these biopsies. The most common variant of Alports is the X-linked. That's about 80%, and that's usually alpha 5 mutation. And median age to end-stage kidney disease is about 25 years. This is mostly obviously in males. The autosomal recessive Alports, which is seen in about 15%, is due to alpha 3 or alpha 4, and this also has a median age to end-stage kidney disease of at a relatively young age. Autosomal dominant is not as common. The difference is really the inheritance pattern and alpha 3, alpha 4 mutation, and this is a much later onset of end-stage kidney disease of about 70 years. And it's very rare to have both ocular and hearing abnormalities in these cases. In fact, the first case is the first family tree that was reported by Dr. Cecil Alport back in 1927 did, obviously no HIPAA back there. They actually named the family and all the siblings and everybody. Is basically your family tree is on display. He reported males and females within this 4 generations that had started back in the 1870s, and he reported up to the 1930s. And he was the first one that really stressed the importance of extrarenal manifestations being hearing loss and then the visual problems. Interestingly, the genotype-phenotype correlation with X-linked outport is present. In other words, it is confusing enough that this disease can be either X-linked or non-X-linked. But in addition to that, the actual type of mutation also matters. So if you have a wide deletion or nonsense or frameshift mutations, your prognosis is a lot worse than if you have a splice mutation, and that has a worse prognosis than it's a missense mutation. So the actual mutation itself can present differently phenotypically, and who presents earlier and who presents later. So on fluorescent, when we look at the alpha-5, so the top left is a control. So you can see staining of the GBM for alpha-5. So this is normal. Panel B is a male patient with Alport's and X-linked Alport, and you can see that there is complete absence of alpha-5 staining. In a female, which will usually have a mosaic type of presentation, you can see this pattern where some areas are normal and some areas are abnormal, and that has to do with the fact that the X chromosome within each cell is randomly inactivated, and whether that inactivation happens in the X chromosome that is a wild type versus the mutant, that cell could present with either expression of the alpha-5 chain or not, and that's why you get this mosaic pattern. So you can have in a female this pattern where you see the mosaic sort of pattern. And the D panel here is actually autosomal recessive, because autosomal recessive is usually alpha-3, alpha-4. The Bowman's capsule, as I mentioned, expresses 5, 5, and 6. So the Bowman's capsule actually stains for alpha-5, whereas the actual tuft does not stain. So this would be an example of an autosomal recessive Alport compared to an X-linked Alport. So there's some interesting genetic presentations there. So what about the crescents here? I found 3 case reports of crescentic Alports. Now, it's really difficult to know, are these epiphenomenon? Does a patient happen to have Alports and they also have an ANCA-negative post-immune crescentic glomerulonephritis or not? There were multiple reports prior to this, but those were all in the era where we didn't have ANCA, so I sort of didn't include those because those could have been ANCA positive. But these 3 cases were since 2005. The first case was in 2005. One of our colleagues, Tony Chang here at University of Chicago, reported this. And this was a 17-year-old who presented with a creatinine of 2.4. The biopsy showed a crescentic GN, ANCA negative. They treated with ACEs and ARBs, prednisone, 1 milligram per kilogram for 6 months, and the patient showed stability of creatinine and improvement in proteinuria at 5 months. So there was some degree of immunosuppression that was given to that patient, but no further immunosuppression beyond just steroid therapy. The second case was a 16-year-old male who had hematuria since age 3, started on ACE inhibition, developed nephrotic syndrome at age 10. Without a biopsy, was started on cyclosporin, which stabilized both the creatinine and reduced the protein, and he was on that for 4 years. And then cyclosporin was tapered off, and a year after, at age 15, he developed AKI. They biopsied him, he had crescentic GN. They resumed prednisone and cyclosporin. His renal function stabilized for about a year or so, and then he took off and progressed to end-stage kidney disease and required a kidney transplant. So that was sort of the second case. And then the last case was about 2 years ago. A patient, 16-year-old male, presented with hypertension and headaches, and biopsy showed crescentic glomerulonephritis, post-immune, and genetic testing was consistent with Alport's. And in this case, no immunosuppression was given. So you have a hodgepodge of sort of few rare case reports of variable treatment patterns. And interestingly, none of these patients, 1 out of the 3 got transplanted, and there was no report of any complications post-transplant in that patient. But in general, Alport's patients who get a kidney transplant due to the abnormality in the type 4 collagen, they can develop antibodies against type 4 collagen. And in fact, what I learned by reading about this for this particular case is that nearly all patients eventually do develop detectable antibody levels to type 4 collagen in the of the allograft, but only about 3%, 2 to 5% develop anti-GBM disease. And as was mentioned in the chat, there are cases of crescentic GN in post-transplant Alports, but that's really due to essentially anti-GBM disease. Our case was a little different and similar to the prior case report. So as I mentioned, I tested her. She was positive for alpha-5 chain of collagen. And then, so for her, I actually ended up giving her steroids and rituximab. And you can kind of see she had, her creatinine was going up. By the time I biopsied her, got the results back and, you know, scratched my head about what to do with her. I sort of thought that, okay, if this is an ANCA negative, post-immune crescentic GN, I would have treated it with Rituxan and prednisone. And if it was Alports, I wouldn't have done anything. And crescentic Alports, we have no data. So I went ahead and treated what could have put her on dialysis, which was the crescentic GN. And it seems like her creatinine is back down to about 1.5. We're about 7-8 months out. She's gotten a 6-month follow-up Rituxan dosing, and so far so good. She's doing okay. You know, most of her symptoms are gone, probably from the steroids. I'm not really sure, you know, how long I'm going to continue to do this, but so far this is the follow-up that I have.
Wonderful. Astrid, you had mentioned, and we unmuted you if you want to speak, but you'd mentioned that possible to exclude an atypical ANCA and that Dr. Niles at Mass General can do this. I was under the impression that these atypical ANCAs were not pathogenic. Obviously, I don't know what I'm talking about, and I'm not trying to be humble at all. Can you elaborate on that a little bit?
We've had cases of, you know, post-immune GN with crescents that were ANCA negative. And then when Dr. Niles did some more elaborative Western blotting and so on to look for atypical ANCAs, he did find some. So we've seen that. I don't know, it's a very rare instance, but I would exclude it in this case because it is strange that there are crescents here, you know, in the absence of any cause for it, you know.
What was the protein that it was directed, the antibody was directed at?
I don't remember it. I have to admit, but there are some ways to test for things outside the ELISA.
In that initial case report from 05 that Tony Chang wrote, he I guess proposed a hypothesis that, you know, maybe the intracapillary pressure in weak areas of the GBM because of the Alports can sort of cause, you know, rupture of the basement membrane and kind of spilling of the inflammation into the Bowman space and cause crescents. That's obviously a proposed hypothesis. I can't prove or disprove that, but that sort of was the thinking that he had, was that's why we're seeing crescents in some of these, you know, native Alports.
In which case,
She may also have multiple things, you know.
Sure.
That's what the renocyte panel will help you with. She could have MYO1E and all these other variants that can also cause a, you know, phenotype similar to Alport syndrome. And if you're like a compound heterozygous or, you know, have multiple defects, you might have a more severe phenotype that might lead to these crescentic reactions. And the last thing I just wanted to point out that some of those glomeruli that were sclerotic, they didn't just look involuted and scarred, they looked hyalinized. You see that sometimes with, you know, collapsing lesions when they heal up. Although that was a true crescent, it had the nice periglomerular inflammation, the breaks in the capsule. So I would say that's absolutely a crescent. But you can also have sometimes collapsing lesions that resemble crescents when they're very severe. And so I would rule out APOL1 risk alleles as well in this patient, especially because she's from, you know, South America or.
So the renocyte would have ruled that out.
We did the renocyte one, and so she did not have APOL.
Okay.
Yeah.
Just throwing that out as another differential.
And it's interesting to think about the physiology there then. I mean, obviously a crescent's a result of a break in the capillary wall. And we usually were thinking that the reason there's a break in the capillary wall is inflammatory mediated post-immune vasculitis, or it's GBM disease, or it's lupus. But in this case, if it's really just the hereditary GBM that finally gets weak enough to break, then there's not really a theoretical role for immunosuppression. because it's not going to prevent further breaks. The break is hereditary. So it's interesting that she responded so well to Rituxan, or maybe her ATN was getting a little bit better or something.
No, but it may be helpful for the inflammatory response that actually comes as a result. I think the unfortunate thing is she's basically, programmed because of her Alports to have progressive renal disease. I mean, her nephrotic syndrome is probably from the Alports more so than, her crescentic disease. What's been the course of her family as far as progression goes? Her sisters, because she has two sisters that have this too, right?
She has a brother and a sister.
Brother and a sister.
Yeah, the sister. So they don't live here. So we don't really. They don't. The dad doesn't go to doctors. All we know is that he has gross hematuria. The sister has had gross hematuria,
but her brother's not on dialysis.
Her brother,
right?
no, her brother is actually doesn't have anything. Apparently, he doesn't have gross hematuria, no hearing problems. I don't know if he's had blood work done. It's kind of a little bit of a black box of a family history, but I know who has gross hematuria. That's all I know.
Yeah. If he's had nothing, it's hard to believe that he's. I mean, it would show up early enough in a male that it's hard to believe that he's. Women, of course, it's always a crapshoot on their age, and like you mentioned, how much the X goes into their kidneys.
I just had a hard time believing that a young girl like her would have Alports, all this family history, and then would have this post-immune crescentic GN, and somehow they would not be related. But I suppose that's possible.
That's why Hickdom's dictum is out there, but as Dr. Glassick said, but.
Yeah, and all those skin manifestations too.
That's a good point. That's a really good point. I mean, she presented with a systemic disease, and maybe that is vasculitis. Maybe it is systemic, and it is not, because those are not symptoms that are associated with Alport by any remote. So maybe maybe it is two things. Yeah. I mean, I give you a lot of credit because you didn't hesitate at all to treat her. You basically are being a pragmatist. Didn't hesitate. You put her on steroids, and it's hard to believe that isn't why her creatinine got better. It's also hard to believe that she wouldn't have got worse without treatment. And you gave her one follow-up dose. My question is, how long are you going to treat her for?
Good question. I mean, I'm going to treat her as an ANCA negative vasculitis, and that's what the pathology showed. And she's doing okay. So I think she's one relapse away from being on dialysis based on the biopsy. So, I think I'm going to maintain her on Rituxan as if I'm treating vasculitis.
Also, throwing out something else, gross hematuria can also have other causes, especially infections, schistosomiasis, for example. So maybe the causes in her siblings or family are not necessarily related to the genetic disease.
So now we've got three things. This is no longer Hickdom's dictum, it's Astrid's triad.
Sorry, I was actually just joining it to see what this is about because I saw that on Twitter today and I was like, oh, I'm going to check out the session. That sounds cool.
We are thrilled to have you. We're really honored. I'm glad. We hope you come back. Now, if you don't come back, we'll be devastated. So we'll think you didn't like it. So, but thanks for joining us because you really added a lot, as everybody always does. Any other comments? Dr. Glassick, you've seen everything 10 times. Have you seen anything like this?
I've never personally seen a case, but as shown in the literature, there are rare cases of crescentic disease with Alports. Whether they represent ANCA negative autoimmune vasculitis, I'm not sure. I think you're using the term ANCA negative vasculitis rather liberally here and wonder whether this is just part of the very broad spectrum of Alport's disease, with the very rare occurrence of a crescentic GN. Who knows?
So you're in favor
I don't think we'll ever be able to resolve that.
You're in favor of Occam here, then?
Yeah.
Yeah, that's what I always like to bet with. But,
yeah, if you like Occam, this is all out.
Well, I think we're going to wrap this up. Thanks, everybody. What a great case, Casey. Thank you so much for sharing it. Thanks for everybody joining us, especially our visitor from the Brigham, Astrid, and Dick's comments. And congratulations on the success with treatment, Dr. Gashti. We'll be, keep your email open. If anybody's not on our email list, let us know. Send one of us an email. We'll include you. Not sure if we're on next week or not, but you'll get an email and we'll tweet it out And until then, everybody stay safe.